All right. Hey, everyone. My name is Zahir Basrai.
I'm Manny Saladan.
And we'd like to welcome you to our first ever webinar on what to expect and for your intern year and some tips to hopefully make that transition a little bit easier. So a little bit about myself. I went to med school in New York and then did my training at both Denver Health and Harbor UCLA. I did a fellowship in ultrasound, finishing all my training in 2014. After that, I took a job in an ER that essentially has med students and interns that rotate with us. So a lot of the tips that we kind of come up with are based off of our experience working with med students transitioning to their intern year. So
Yeah, I went to med school at UCLA and then met Zahir. He was my senior resident at Harbor, and now working together making this med ed project. I think one of the things that gets lost in medical education is just preparing people for the transition between the preclinical years and the clinical years. You're so focused on going from the classroom to the clinic that once you become an intern, you think you know what to do, but you really don't.
Yeah. And there's some subtle tips, like we're oftentimes rewarded in medical school for things that you're not really going to get rewarded for in residency and internship, and understanding what's kind of expected of you so that you can perform well is always nice. So instead of keeping all that in the dark, we figure we could give you some really basic tips. You've probably heard a lot of what we're going to talk about, but I know that most programs are getting fired up over the next week or two. So hopefully this will be a good reminder of some high yield topics that'll allow you to hit the ground running. So
yeah, and just demystifying a lot of these kind of unspoken rules and expectations.
We want to keep this webinar super relaxed. So if you have any questions or comments, feel free to go ahead and put them in the chat section of this webinar, and we'll get to them at the end. So I guess what we'll do is we'll talk for maybe 10 or 15 minutes just to go through a little presentation that we have discussing some high yield tips for efficiency. And after that, we're more than happy to hang around and answer any questions. So let's go ahead and get started. Like the lecture and the title of it is How to Be an Efficient Intern. So again, we're just going to present a couple of quick and simple tips that'll remind you of what the most important parts are of being a good intern. Again, these aren't the same things that you were rewarded for as a medical student. So it's important to kind of keep this in the forefront. So let's go ahead and kind of get started. Now, the idea is that in medical school, you were rewarded for being extremely thorough and spending significant amount of time on one or two patients. When you start as an intern, you're evaluated more so on your ability to juggle multiple patients, like 10 or 12 patients. So it's still important to be thorough, but you have to be able to understand what's important and be able to focus on that, and in order to be as efficient as possible.
Yeah, I mean, the hard part is balancing being the worker bee of the whole team while at the same time learning medicine. But most of your tasks are going to be non-medical tasks. It's a lot of administrative things. And eventually, once you kind of gain the trust of the team, that's when people start throwing you kind of scraps and be like, hey, maybe you get to do this API, or maybe I'll have you do this IND, but you really have to be solid with the administrative stuff, which is not something that you learn in medical school.
Yeah. So our first tip is to move to the critical differential diagnosis as soon as possible. In medical school, we're oftentimes taught that there is only one right answer for any particular question. For example, we're given, I would say, more multiple choice tests than I think we really need. But in those multiple choice tests, you're usually only given the opportunity to give one answer. Now, and you're rewarded for that answer. Okay, so Moving on to like more of the meat of what this slide means or what this message is, it's always nice to be able to catch the zebra and to make that diagnosis, and people will be excited if you do it. But people will be pissed and upset if you miss something that's life-threatening. So more than starting out looking for either a benign etiology or a zebra, anytime you receive a page or see a new patient, you should immediately begin to formulate in your mind what the critical differential diagnosis is. That way, let's say you miss what the true diagnosis is, at least it won't kill the patient.
Yeah, so in a move to be more efficient, you really don't want to focus on thinking about those zebras. And like Zahir's saying, you may get multiple pages on patients that you may have little familiarity with. So really making it clear in your head how to approach these patients that you don't know, and changing the format that you're used to is what's going to help you be more efficient and be able to focus on both the administrative as well as the clinical tasks.
Yeah, so let's kind of go over how this looks. So the classic workflow that we're used to is to start with the chief complaint, then get a very broad history, broad physical exam, develop an extensive differential diagnosis, and then figure out what labs, imaging, treatment, and disposition you need. What we would recommend is to move your differential diagnosis to after the chief complaint. By doing this, you're not just developing any differential diagnosis, you're developing a critical differential of diseases and processes that you absolutely cannot miss. So, for example, for chest pain, if a patient complains of that, or you get a page at 2 a.m. that a patient you're cross-covering and you really don't know much about them is having chest pain, you have to start from scratch. And the first things that you'd want to do is rule out things like ACS, pneumonia, pneumothorax, aortic dissection, pulmonary embolism, etc. The nice thing about that is by having this list, you can go ahead and focus in on your history and physical exam. So you're not just asking a bunch of open-ended questions and allowing your patient to take you down a road that keeps you in the room for an hour, because it's just really hard to get to the meat of what the patient is complaining of. So by focusing on the critical differential, you'll remember to ask very specific questions, specifically looking at things that you cannot miss.
This is really important. When you are a part of the team and you get the page, you can really help offload your seniors' workload by starting this differential. By starting the workup for a patient, and instead of just being a secretary or somebody who's just in the middle, just passing and playing a game of telephone, you take that chest pain patient, you start the evaluation, and then you can then report to your seniors like, hey, this patient with chest pain, there's a patient on our list with chest pain on the floor. I've already thought about the X, Y, and Z things. Kind of ruled out the critical differential. So now we can hone in on what's actually going on. And then you can ask them more advanced questions or more direct questions and to get to the bottom of what's causing that chest pain.
Yeah, so this is what it looks like, the new workflow. You'll have your chief complaint, your critical differential diagnosis, your history, physical exam. You can reassess your differential at this point to either add things like maybe your patient has a wild card, like they're immunosuppressed, or they have a recent surgery. So you may need to add a couple of more things to your critical differential. And then you can determine what are the appropriate labs, imaging, and treatment for the patient.
Yeah, because it's all guided from that critical differential. So I remember when I was a med student, one of the things that I struggled with was the fear that I didn't ask all the questions I needed to ask. And so what ended up happening, and the reason my encounters lasted, for 30, 40 minutes, and everybody was wondering where the heck I was, is because I was just going through this laundry list of random questions so that whenever my attending asked me, hey, did you ask them who their second grade teacher was? I had the answer, right? And so in reality, when you're, going from being a medical student to an intern, you have to be more efficient. And you just can't sit there asking 40 minutes of questions. So for every chief complaint, you have to develop a working critical differential, and that working critical differential will tell you what to ask. To just give you a kind of more defined example, if a PE is on your critical differential for chest pain, then you should know to ask the patient, do they have any history of PE or DVT? Have they had any long flights, right? So things that would cue you to be more worried or maybe less worried about PE. And then you know what to look for on physical exam, right? So there's not much in a physical exam for PE that's going to tell you a PE is going on other than maybe a DVT, right? And so that's really kind of what's helping you focus with your encounter.
Another thing that's really nice about this is understanding that your attendings, when you're presenting to them, are specifically in trying to rule out these critical differential diagnoses. So in your history, when you present to them, they're waiting to hear if the patient is in fact having tearing, ripping chest pain that's radiating to their back, or if they on physical exam have evidence of symmetric or asymmetric pulses, right? So because you know now what the attendings are specifically listening for, you can include those nuggets into your presentations for them. It'll come off as you knowing a lot more, or it'll come off as if you know what you're doing and how to efficiently evaluate these patients.
Yeah, like it's a lot better that you paint that story in a very concise way than it is to know some random esoteric fact. Yeah. Patient.
Like the patient has a puppy that they just got and snuggle with.
That's not as impressive as having a very tight presentation.
Yeah. So that's that part. Let's go ahead and kind of fire through this. So this was our example that we gave. So as we said, for chest pain, ACS, pneumonia, pneumothorax, aortic dissection, pulmonary embolism. So, oops, sorry about that. But I think we've kind of gone through this topic pretty in depth, but we really think that this is something that we've seen a lot of our med students and interns struggle with, especially when they have a patient who's not very linear. You want to try and get in and out of your encounter with your patients within 20 minutes. And after those 20 minutes, you want to have a good, solid plan. So if it's taking you longer to develop a solid plan, you want to kind of reassess your workflow and then figure out if there's other ways to be efficient. Yeah. One thing we want to say is we totally get that everyone kind of thinks and works in different ways. So this is just stuff that we found to be really helpful. And if it's something that's really helpful for you, we hope that you can apply it and it'll work. So.
Yeah, the goal here is to simplify things as much as you can so that you can then add layers of complexity as you become more sophisticated in your training. And honestly, when you have a patient who's very disorganized or a patient who's a poor historian, usually the issue is you can't figure out what the acute chief complaint is. And so it's really important to first start with what the chief complaint is. And that sometimes may be what the patient says, that sometimes may be what a nurse tells you, or what you notice, right? So the patient may say they have toe pain and you walk into the room, if they're an AFib with RVR, chief complaint is no longer toe pain, right? The chief complaint is AFib with RVR, and you build a differential off that, because that helps you build a framework, and then you won't feel so lost, right? Because when the patient's just kind of going all over the place and giving you the laundry list of chief complaints, then you're just going to feel stressed out because you're like, wow, I have 9 other patients on my list. And if each of them gives me a laundry list of stuff, I'm just going to be lost.
Yeah.
So a chief complaint.
You got to love the PAN positive review system patients. All right, let's keep going. The next one is be an EHR Master. So I didn't fully understand how important this was when I first started, and it really bit me in the butt, because I remember my first admission on my first day of intern year took me over an hour to write up the HMP and to get the admit orders in and dispo orders in.
Did you even have EHR when you were training?
You know what? This guy. All right. Yes, they did. It was written in C++. No. But the idea is you really want to know the basics. So the basics would be, how do I put an order in? How do I admit a patient? And how do I dispo a patient? So I know we had 4 or 6 hour one day EHR training sessions where it really felt like I wanted to just leave the room, or I'm trying to think of something nice to say, but I can't. But if you're going to pay attention to anything in those really long classes, it should be, how do I make templates for my notes and decision making? How do I put in an order? How do I admit a patient? And how do I dispo a patient? Because that's most of the functionality you need. After that, you can figure out everything else as you kind of go through like your training, because most of it is hands-on experience that'll allow you to be as efficient.
Yeah, you can't stress that enough. As the intern, you're the primary note writer. So taking the time to get your templates set up earlier on in your training is better, right? The sooner you do it, the more efficient you'll be later on in the year. And you're also as the intern, you're also the person that does the admissions, right? Puts in the orders, make sure the orders are followed. And if you do the orders correctly, that leads to less pages for you or whoever you're signing the patient out to, because then the nurse won't have as many questions to ask overnight when little things pop up. And so knowing that is very important. And then ultimately, where you really shine as an intern is clearing your list of patients, right? And the way you do that is by not just learning how to do discharges on the EHR, the electronic health record, but also how to move patients along and get them discharged, right? So talk to the social worker and so on. But yeah, learning these three things at least on the EHR is really important.
Cool. So that's tip number 2. Tip number 3, and this is going to feel really hard because as a med student, your note was the longest and you were applauded and celebrated for long, thorough notes. You're going to need to break that. And really what's most important is to be highly efficient with your note. So you want to focus in on all the components of the critical differential in your history and physical. And what you really want to do is spend most of your time writing out the assessment and plan. A lot of what the note is, for you at least, will be what you read off of during rounds. So make sure you have all the information that you need in order to adequately present a patient in the morning.
Yeah, and the note writing is different on a new patient versus a patient that you know, right? So definitely short notes for patients that are known to you and you're doing a kind of a reassessment note. For an admission note, I agree. I think the notes overall should be short, especially if you have 10 new admissions coming in. You can't be sitting around spending like a lot of time on the notes. And I think where people really kind of lose time is by trying to make their HPI really long. But this is where, again, the plug for the critical differential is important. Is the most important thing to include in your HPI are any pertinent positive or negative historical things from your critical differential, right? So if somebody has an aortic dissection, or you're wondering if somebody with chest pain has an aortic dissection, you're asking for, did the patient have ripping or tearing chest pain? Did it radiate to the back specifically, right? You don't have to ask just random stuff. And then really focus in on your assessment and plan and listing out that you've ruled out the big stuff. And then what is your future workup going to be if you're trying to rule in things at that point? Because everybody reads the assessment plan. Everybody will skip through your very long, beautiful 5-paragraph HPI and go straight to the assessment plan. They're going to scroll right down, right? They're not going to go, read your narrative summary of the long HPI that you got.
Yeah. I mean, we've seen this time and time again. And even at the end of intern year, we've seen a lot of our interns that really will spend way too much time on their notes. And the issue with that is it takes away from their ability to spend time at the bedside, to actively treat the patient. It makes them feel very overwhelmed every time they have to pick up a new patient because they know they have to write another note. So if you can make your note writing as painless as possible, whether that's, again, being an EHR master and having your templates, that'll just allow you to have much more confidence as you pick up more and more patients.
Yeah, I mean, note writing should never take precedent over clinical tasks. And it's much more important for your learning process to really hone in on your physical exam skills, really kind of hone in and think about what's going on with the patient, and less about writing all that down. Right. And short notes doesn't mean you're writing bad notes. It just means that you want to be as concise as possible.
Yeah. So we've been talking a lot so far. We just want to check to see if anyone has any questions. We'll just stop for a couple of seconds because there's a little bit of a delay.
We're basically saying, Shirley, do you have any questions?
All right. That's good. I've been told by my producer that we need to wait a little bit longer.
Okay.
Oh, we got the green light. Okay, we're good.
like
We're good. Okay, let's go. All right. So again, just to hammer home the points. Man, I probably should have reviewed the slide deck again because I didn't realize this was going to be here. But so again, the most important section is your MDM and your assessment and plan. Your history and physical exam are more to help get you through rounds.
So let's take sorry to take a little break here. So we do have one question from Shirley, and her question is, as a medical student, I'm editorializing this, but as a medical student, I should be doing longer and more thorough notes. I'm going to do a long sigh there. As medical students, it's a little bit harder because it's almost like a performative art, and you never really know what somebody wants out of you. So as a medical student, I would ask every new team that you go work for to just ask what their expectations are for note writing as well, because it's really going to have to be custom tailored to their what they're used to. Personally, what I would say, what we're saying for interns should apply to medical students, because I think note writing is important, but it shouldn't be this like long narrative thing. It really should be as concise as possible. And really the take home message is take 80% of your time writing the assessment and plan. And what you're writing in the assessment and plan is not just what you did, but what you thought and why you thought what you thought, right? So for example, if you're saying, I don't think this patient has an aortic dissection, what you're writing out in your assessment and plan is, I considered aortic dissection, but the patient reported no ripping, tearing pain. It did not radiate to the back, so he did not have aortic type pain. I looked at the chest x-ray, there was no widened mediastinum, and the patient has no other risk factors for aortic dissection. Therefore, that is why I thought aortic dissection was less likely, right? So that thought process is what you're trying to do, because you're communicating to other doctors who haven't seen this patient what you saw, what you thought, and why you thought what you thought.
And Shirley, I think the hardest part about being a med student is learning the different languages for each of your rotation. So as Manuel said, like, you want to be able to ask the members of your team what they expect of you for your note writing. But I can give you an example that on internal medicine, the note is going to be much longer, much more thorough than a surgical note, which is a lot more focused and just dealing with the primary surgical issue. So it's best to kind of look at your team, look at what they value. Is it, as a medical student, do they just want you to know every single detail about your patient, or do they want you to be able to help them plow through patients in their surgical clinic? If it's the other one, then you want to be a little bit more efficient on your notes. If it's the first one, then you want to spend more time developing your notes and making sure you include all the details.
And I don't want to set the precedent of longer note equals better note. It's really all about being concise. That's the most important part, because I'll be honest with you, I've seen very long notes that have a lot of words but don't say anything.
Yeah.
So really what matters is more what you're saying, right? But I agree, again, you have to really feel out your team and see what they value, because unfortunately every rotation is different.
Yeah. Cool. We did notice that there is one additional person watching, and we don't know who this mystery person is, but we like to say we love you. And if you'd like to respond to the chat, that would be awesome. Or introduce yourself, but no pressure, because we love you either way.
I mean, it seems like you're giving them a lot of pressure.
No pressure at all. No pressure.
You said you love them.
I mean, okay, now that I think about it, it sounds a little extreme. I don't know how to backtrack from
Now
this.
I feel like I have to say I love them too.
All right. Okay. Let's just make sure we're good. Shirley commented again. Okay, cool. She said thank you. All right. All right, let's keep going. The next thing is to stay organized. I think that's really important. So you want to make sure you have a good method for a to-do list. And again, every rotation you have will kind of have their own system, whether it's on their sign-out sheets, but you just want to make sure that you can quickly and efficiently check the boxes as you go through it. So let's kind of go through a typical pre-rounds to-do list for your medicine and surgical wards. So you definitely want to, ensure that you followed up the vital signs and eyes and nose for your patients. You've gone ahead and collected all the labs, cultures, and imaging results from the day prior. And you've looked up any consultant recs, because that'll be the first things that you'll need to present in your SOAP note. And then with regards to post round, so after you're done rounding on your patients, then it's another scramble to just try and get everything done for your patient. So start with the discharges. If you have a patient who's ready to go home, execute the discharge for that patient. If there's a consult, try to get that consult in as early as possible. Your consultant will be much nicer on the phone if you consult them earlier in the day versus at 3 a.m. The next thing would be to ensure that if there are any electrolytes that need to be repleted, that you replete them. If there are any new med orders, that you put those in. And finally, you want to make sure that all your labs and imaging orders for the next day is done. And if you have time, one of the things that I used to do back in the day when we used to use paper charts is I would actually prep my next day's progress note. So if I had 12 patients, I would write up a skeleton version of my SOAP note, assuming that the physical exam hadn't really changed and that most of the assessment and plan hadn't changed as well.
Yeah, and this is where you really have to develop a workflow. And again, it's going to be different whether you're on a medical versus a surgical service. But figuring out what that workflow is and asking your senior resident to kind of work you through it is going to be important. But the main highlights of being a good intern is dispositions, right? The goal at the end of the day is to have your list be shorter at the end of the day than it was at the beginning of the day, right? And so how do you do that is by prioritizing discharges and consults, right? Discharges are the top priority because that means you're winning the game, right? You're clearing your patient list. Consults are second most important because sometimes a decision to discharge is based off a consult, right? Or a decision to do a procedure is based off a consult. So you want to get that out early, because if the consultant doesn't get your consult until 3:30 p.m. and they're out by 4 p.m., you're going to have that patient be in-house for another day, right? And then you lost that game, right? And so getting those two priorities is important. And then ultimately the rest of the clinical stuff comes last, right? And really the last thing is your note writing. That's the lowest priority thing to do.
And the whole idea as an intern is to make sure that you don't miss anything critical. If there is a critical lab or a critical order or a critical result that you need to follow up on, you're the person that everyone's going to look to make sure that that information or that order or that process has been initiated. So make sure that you keep a very well-organized to-do list. And I'm not one of those people who has, or I wasn't before residency, I didn't really have a lot of to-do lists. But what I would do is, again, we had paper sign-outs with our entire team information. On the right hand or the left hand margin, I would write up little check boxes with all of these requirements. And then only after all of them had been checked off would I know that my day was complete.
Yeah, and this our help may be a little outdated here, because I also there are little sheets and templates that were handed out to us when we were interns and when we were transitioning from paper charts to EHR. But now I believe most electronic health records, if not all, have a standardized printout and patient lists. But the idea is the same, which is you have to make those little check marks, make those little boxes of all your to-do lists, and don't finish the day, don't leave until you've completed every single one of those tasks. Because there's nothing worse than an intern who was told to do something and then didn't do it, and then we don't find out until the next day, or the overnight team gets stuck with that workload.
Yeah. Cool. Next thing we just wanted to briefly touch base about is signouts. So I'll let Manuel kind of talk about it.
Yeah, so signouts is and patient handoffs are something that almost seem like an afterthought in training, but it really is important because it's where a lot of medical error can happen. And it's also a point where people don't take as much ownership of patients, right? So when you're passing on you know your patient very well, and you're passing out to the overnight team who's really going to hold the patient for 12 hours at most, and so they also have 60, 70 patients, so they may not take as much ownership of your patient. So there's where a lot of errors can happen. So there's been a push to have a standardized way to do this. IPASS is that it seems to be the kind of the industry standard now. And IPASS stands for I, illness severity, P, patient summary, A, action list, S, situation awareness and contingency plans, and then the last S, synthesis by the receiver. And so this kind of standardized approach is similar to what we do in EM sign out. So what I learned in EM was you start with what is left to do for patients, right? So this is your to-do list for the night team. And then after that, you do a one-liner of like, well, this is the patient. So it gives you the context. And within that one-liner, you give, this is a very sick patient. This is a stable patient, right? Or this is a patient that may be, they're stable now, but they may deteriorate for X, Y, and Z reasons overnight. And that kind of goes through your kind of situation awareness. And then the last thing you want to do is you want to make sure you have closed loop communication. And so you have the person who received the sign out give you a very brief, like, yes, I understand what you told me, and just a very brief summary of what you said. Again, EM signouts are a little different, but this IPASS format is something that is you can Google, and you can find a lot of literature on it to learn more about it. But again, everybody will do it differently, but really focus on being somebody who does good handouts, because you'll see when you're on the receiving end of those signouts, you'll know an intern who really doesn't understand what's going on, and you'll know the intern who's like really on top of it. And this is how you differentiate yourself.
Yeah. All right, let's keep going. The next thing that we can talk about is to know your resources. So everyone seems to love UpToDate. And what I'll say is it's great if you have a lot of time to spend reading, but when you're on clinical shifts or you're rounding on your patients, you really don't have that much time. So you need to have efficient resources. So I'm going to plug wickham.org. It's an emergency medicine based website, but it can be used in all areas of the hospital. It distills down the information to something that is consumable very rapidly. It'll allow you to make decisions with regards to your critical differentials and how you want to intervene on the patient, what labs you want to order. It just simplifies all of that. It's a free open access platform. So we used it a lot, especially during our residency training. And we even use it now as attendings because it's so helpful. So I would recommend definitely when you're in a time crunch or you're trying to work efficiently, if you don't want to use Wickham, maybe try to find another resource that allows you to rapidly access information that is potentially distilled down a little bit more than UpToDate. With that said, when you go home or you have some extra time, you are going to want to do deep dives into your whatever topic that your patient has. And to do that, you can use UpToDate, but I would even highlight review articles. So especially looking at PubMed or whatever resource you want to use to try and search for review articles, you can get, I think, a lot more brownie points, especially from your attendings, if during the rounds the next day, you in fact reference a specific review article that you're using information from. So UpToDate is great, but I would say for me personally, when I am on shift, I'm using Wickham. When I'm at home or I'm trying to do a deeper dive, I try to use more of a review article from one of the top journals.
Yeah, I was trying to figure out what was one of the core medical student books that we use, but to try to give an analogy. But I think of WikiM as the first aid for medicine. So it's a good place for when you just want to quickly reference something. It's up to date, and it gives you very kind of clear guidance on how to start a process. And up to date is more of like your reference, like your big reference book. If you're somebody in medicine, it's like your Harrisons. If you're somebody in EM, it's your Rosens, right? And so that's something that where you have like more, more relaxed, more time. But when you're just, you're in a day where you're doing a ton of admissions, it might be easier to reference WikiM than it is up to date. A plug for developing your workflow here. This is really important. You have to, for the first few days of your intern year, really try to figure out like, how am I going to approach every new patient? Because after a while, you'll notice that there's a pretty standardized way to approach any patient, and developing that workflow is important. So like, for me, to give you an example, when I came down to see a new patient that was being admitted, I would look at what were the active chief complaints for that patient. I would look on WikiM for every single one of those active chief complaints. And then that would guide what my initial workup was going to be. I would write that up, and then I would move on to the next patient. And then the next day, now that I know this patient a little bit better, is and we already had the results of the first round of workups that we were doing. Then I would look to up to date to see like, look, everything came back negative. What's next, right? And so that's kind of one of the workflows that I had, and then you had just to develop your own.
Yeah. The next thing that is important is also using your magical cell phones. So what I would say is this actually goes back more towards your to-do lists. You're going to have instances where you're going to need to follow up results or place an order at a specific time. And I can't tell you how valuable having an alarm clock is on your phone, because it's so easy to forget these time-sensitive things when you have a bunch of stuff you're kind of looking after. So just a quick plug for that. I'm sure there are a lot more other apps and tools that you can use. So just kind of keep your like eyes open for anything that could be helpful. All right, so I think this is an important slide. It kind of talks about the mindset. Now, internship and the transition is really hard, and it's important to recognize that and to be ready for it, right? You can't live in a state of denial about that. You have to basically give yourself to your internship and your residency from day one, and you just have to be ready for it. So one of the things that I developed that kind of helped with mindset is a 75-25 rule, which basically means that 75% of the time the days are going to be super hard, and 25% of the time the days will be like better or easier. And the reason why I had to think of my internship this way is because by coming in knowing that I was going to get worked, any time that I had an easier day, it was a pleasant surprise. Versus when I first started, I thought most of my days were going to be okay. And so whenever I had a hard day, which ended up being more often than I would have wanted to, I would be really disappointed. I would feel beat down. So the idea is to kind of have a strong mental barrier and a realistic approach for when you start, so that you can set realistic expectations. So you just kind of have to give yourself to the system. You want to try and minimize any outside distractors. Like when I first started residency, I was in Denver, and luckily I didn't really know anyone there. So I was able to develop my social network within the hospital. And I honestly really enjoyed my internship and residency, because it kind of became where my life was and where I was able to, where I spent most of my time. So this is like hard. It's hard to admit this. It's hard to kind of advocate for this type of system, because it isn't the most positive system. But what I would say is, however you work on your mental health and whatever mindset you want to go into residency, use it and go for it. But if this works for you, use it. If not, use whatever it takes. But you're going to find that a lot of people around you are going to be getting burnt out. You will probably get burnt out at some point. It's like normal, which is a really messed up thing to say about our field. But what I will say is be strong in your mindset. Be ironclad. Like have a focus and approach residency with that mindset because it'll serve you throughout your entire internship.
Yeah, I mean, it just comes down to attitude and perspective. Unfortunately, as an intern, you're at the bottom of the totem pole and you don't get much say. And the way residency training is, it's very militaristic and it's very inhumane at times. And while I wouldn't call it normal per se, it's what is expected to happen, and we haven't figured out a better way to train clinicians. But ultimately, what you want is always show up to work expecting to work, right? Because if you show up to work expecting a chill day, then you're only going to get disappointed. And then every time you get a call or every time you see a new patient, you're going to be annoyed and annoyed and annoyed. And that's what leads to medical error, and that's what leads to bad patient care. Right. So you really have to make sure that your mindset is such that you're ready to work when you show up to work. And then when it turns out that it's a light day, you're happy. Right. So it's resetting your expectations. The other thing is your residency experience is going to be largely determined on how you react with to a lot of different personalities. Right. For example, if you're an ER intern, or if you're going into ER in general, you're going to get a lot of crap from a lot of different specialties, right? So being able to know how to deal with these different personalities is going to be important. And lastly, whether you use the 75-25 rule or whatever you end up using, just remember that burnout is real. Burnout will and may happen to you multiple times throughout your training, and keeping that front and center so that you're actively trying to find ways to relieve that burnout is going to be important. And it may not be obviously apparent. A lot of the times I wasn't really aware that I was burned out until afterwards. I was like, wow, like, why did I blow up on that consultant, or why did I blow up on this coworker? Or why did, you really don't learn, you don't realize it in real time. So being aware that burnout is real, burnout will happen to you. It may happen more than once, and then trying to find ways to battle that is going to be important.
Yeah. Another thing I want to point out is with the 75-25 rule, as you go through your training, those numbers will actually change, and for the better. So as you get towards the end of your intern year, you'll have more good days than you will bad days. But it's just something that takes some time. In terms of the no plans after work or expect to stay late part, I mean, again, it's a hard thing to kind of say because it shouldn't ever be that way, but you will get like a last minute admission that's going to keep you at work longer, or you are going to have a patient who decompensates that's going to make you stay later. And if you have plans or you don't expect to stay late, that's when you can get really upset and down in the pits. Or down in the dumps. Like you just really want to make sure that you recognize that this is the time to kind of dive deep into all of this. So like a silly example of this was, I think it was like my 4th day during intern year, and me and my co-intern had plans to go see a movie, and I guess I'm not embarrassed, but maybe I should be, but we were going to go see Transformers in IMAX 3D. And sure enough, right before we were about to leave and we had everything all done, we both got admissions. We both ended up staying 2 hours after our shift. And I was so crushed. And again, it's silly because it was like Transformers, and we all know how wonderful those movies are. But in any sense, it just kind of taught me to have realistic expectations. So we'll kind of keep.
It's got to be flexible.
Yeah. Wow, we ended up talking a little bit more than we expected, but I think we're both really passionate about this topic because honestly, it's such a big deal. And we work with interns from anesthesia and internal medicine.
Did you just say anesthesia?
Anesthesia. I'm trying to enunciate. And we see how hard the transition is, and we felt very passionate about trying to provide and advocate for resources that would make this transition easier. So we want to wish you all the best. We know how hard it is, and just keep your head above the water as much as you can.
Yeah, I mean, intern year is hard. I think coming to the realization that you're in a system that you have very little control over, and you're also in a system where you don't get very much orientation sometimes as to like what your expectations are, and it's constantly changing depending on what service you're on. It makes it hard. So I think what you have to do is develop kind of a workflow for yourself and an understanding of what are the basics that you need to cover, and then slowly adding layers of complexity based on what rotation you're on. And that's what we're kind of trying to aim here with what we're doing in this video and the website that we have, is just giving you those basics, and then you take that and run with it and add to it, because it's hard. Transitioning from the preclinical to clinical years is hard, and then transitioning from being a medical student to an intern is hard, because being a physician, being a doctor, and interacting with patients, you're playing with live bullets is a big responsibility, and it's also very difficult.
Yeah. So at this point, we're done with like the lecture part. If you have any questions, just use the chat section of YouTube.
Yeah, Shirley, just use the chat section.
And yeah, my producer is telling me we're still on this delay.
I'm pretty sure I requested a cold soda a couple hours ago.
Yeah, this production value is just woo. We still gotta wait. Okay. But yeah, another thing that I'll say is, even as we're waiting for anyone.
Shirley has a question.
Oh, Shirley has a question.
Also, the WHO has classifications around burnout. There's a link.
Really?
Oh.
So producer's saying that WHO has burnout criteria, and there is a link.
And it's more than just 2 millimeters of ST elevations in the anterior leads. So.
So Shirley's asking how we personally dealt with burnout. Chief?
Yeah, I would say for me, I think, again, having the right mindset really helped, because by having the right expectations, it made it so that I wasn't constantly feeling down about myself. Another thing is, we're all type A, and we always strive to be the best possible, but when you start, it's very hard to live up to the expectations that you have. There's this constant sense of not knowing and feeling like you're not performing well, or you don't know what you're doing. Like it's very easy to kind of feel bad about. It was very easy for me to feel bad about myself, or to feel as if I'm not doing well. So it's important to have, again, realistic expectations about your performance and what you're able to do, but to always strive to be the best that you can. I think that's the whole part of like the cheesy word grit, and just trying to, it's not cheesy. I actually really believe in grit, but that's the whole idea of grit, and like understanding that you will fail, you will have times that you don't succeed, and you just have to push through it. And then the other thing is, setting realistic boundaries. So you're going to have a lot of friends who are getting married, that you're going to get invited to, and it's going to be really hard, but you need to set boundaries for yourself so that you don't overextend yourself. You want to be able to take care of yourself and I tried to focus all my energies towards residency. So that kind of helped with my burnout. I would say the hardest thing to kind of deal with was difficult personalities. So attendings who were really tough, But if you walk in knowing that's what the day is going to be like, you suck it up for that little bit and then you move on with the rest of it. I'm trying to think of other things. I mean, another thing that's really important, but again, somewhat overstated, is getting enough sleep and making sure you're eating well. So cafeteria food sucks. It's usually really unhealthy. If you can, exercise. Although I do not recommend doing push-ups on the ER floor because it may make you feel like you're getting stronger, but you'll probably catch an infection. So, but
I mean, burnout. I think burnout is different for everybody, and you have to kind of realize what is it about medical training that is going to burn you out. But as Zahir was saying, managing your expectations is an important part, right? So depending on what attitude you show up to work with, that's gonna lead to more or less burnout, right? So as long as you understand that residency is a special time and it's the only time you get to calibrate yourself to be a good doctor, then you'll show up to work expecting to work, and then you won't be as annoyed when there's that new admission, right? Or you won't be as annoyed when you get that call from the nurse saying X, Y, and Z things, right? Yeah. The other thing is setting yourself up to succeed is not just an attitude-based thing, but it's also making sure that you've surrounded yourself with a network of friends that you can plug into and that understand that you're not missing, big life events because you don't like them or because you don't want to go to them. Is a lot of times medical training doesn't allow you to do that. And so having a support network, whether it's your family members, your friends, is really important. I think for me, one thing that helped me was reaching out to non-medical friends and having a good mix of both medical and non-medical friends to where when I was off, I can kind of just unwind. And that was important to me because I'm a pretty social person. So going to concerts, going to movies. Lastly, is just understanding what during the day is causing you to be burned out. Is it because you show up to work and you just always feel tired? And if that's the case, then really you need to value sleep more. Is it because you show up to work and you just feel like you just don't have the competence in doing an IND? Then maybe next time you prioritize studying IND instead of going through page one, chapter one of Rosen's or Harrison's. It's really going to have to be you being honest with yourself as to what's stressing you out, and then creating a system that allows you to relieve that stress. It really is individual, but don't let yourself get lost. Yes, this training is hard. Yes, you have to prioritize it, but no, it shouldn't be your whole life. Yeah, I don't know, that was kind of long-winded, but
no, I think that's good.
Yeah.
Everyone's different, and that's an important thing. Is there is no one true solution. It's just all about figuring out what centers you and
so
makes
personally,
you feel better.
If you're asking directly personally, for me it was I love music, methyl. So I love discovering new bands and going to concerts. So that's one thing I did a lot in LA. I love playing music, so then you kind of do that on your own time. Mm-hmm. Giving yourself a little gifts here and there, like buying a new amp or a new bass, whatever. Again, it's all personal, right? And then getting to travel when I could.
Yeah. And that's another thing is ask the people that are going through it with you or some of your seniors how they battle burnout. And it's kind of like medical education. You're going to be learning a lot of different styles. It's all about what works for you. So it's good to be exposed to as much as possible so that you can pick and choose what your practice pattern is going to be, how you deal with burnout, all that other stuff. So yeah, hopefully that helps. Thank you, Shirley, for that wonderful question.
Shirley's so good, man. She had 2 questions. I don't know if I would have had 2 questions at that time.
Yeah. But look, we're always here for you. So you're welcome to shoot us emails, to message us. We'll call you. We understand how hard this is, and we want to make sure that you understand that we are a resource that you can always utilize. So
I'm not sure if I will call you, but definitely we're a resource. Send an email.
Yeah. All right. Is there any other questions or anything else we can help with? I'm just gonna stare at our producer until she says we can wrap
I'm gonna
it
start
up.
listing bands. So
Yeah.
Tame Impala is pretty good. Pond, pretty good.
Shirley said thank you.
Oh.
That would be helpful.
Cool.
In 2 years. In 2 years is outdated, Shirley. In 2 years we'll be like we'll be training with robots.
Black Mirror.
Yeah.
But cool. I guess we'll go ahead and wrap up then. And again, if you have any questions, feel free to message us. You can send us a tweet, Twitter message.
The Twitter machine.
Our handle is at numose.med, as well as.
Let me look it up. What's your?
Just the numose.med.
Yeah.
We also can be reached at numose.med. I think our Facebook is also numose.med, so if you just search that, that'll work. Our email is numosehelp@gmail.com, or is here@numose.com. You can just check the show notes or go to our website. That was a super long-winded contact.
Yeah.
We should have practiced that. That was
I think we spent more time on that than on the critical differential.
But this was a lot of fun.
Yeah.
All right. Cool. Have a good one. Best of luck with everything.
And we're gonna thank our producer.
Oh yeah.
Anna.
Let's see. She's like over here. She's trying to run to the bathroom, but there she is. Okay. All right. Okay. And she put her jacket up, but it's too late.
Yeah.
We already got
She took
it.
the Rocky down.
All right. Bye.